So Cara Lewis is, I don't even know if she needs an introduction. I think everybody has definitely heard of her, followed her work. She is the Deputy Director of CTRIS, the Center for Translational Research and Implementation Science at NHLBI. Dr. Lewis has a Ph.D. in clinical psychology with a research focus on advancing pragmatic and rigorous measures and methods of implementation science and practice, informing tailored approaches to implementing evidence-based interventions. She is an implementation science methodologist who seeks to influence change across a broad field of diseases, settings, and stakeholder groups. She has been a driving force in elevating the importance of implementation mechanisms, emphasizing how study mechanisms of change may improve tailoring, optimizing, and scaling of effective implementation strategies. Prior to joining NHLBI, she was a senior investigator at Kaiser Permanente, Washington Health Research Institute in Seattle. She served as an affiliate faculty member of the Department of Psychiatry and Behavioral Sciences. And she received her PhD and MS in psychology from the University of Oregon, completed her residency at the University of Washington, and then moved to a faculty position at Indiana University's Department of Psychology, Brain Sciences before joining KP WHRI. So her expertise in implementation science has led to several leadership roles, including serving as the president of the Society of Implementation Research Collaboration, CIRC, and co-founding editor-in-chief of Implementation Research and Practice, co-editor of Practice Implementation Science. She is recognized as one of the most highly cited social scientists globally in the top 1%. So it's such a pleasure to have her here for this, for our Roybal Center for Fearless Behavior Change. As many of you know, this is a renewal of our Roybal Center, and we're really focused on really testing interventions from stage 2 to implementation research, stage 5 implementation research around really elucidating some of the mechanisms in behavioral research. And so a topic this year has been implementation science, of not just thinking about implementation from the very beginning, but also really thinking about mechanisms as we're testing implementation strategies. And so it's such a delight to have Cara speak to us. And so without further ado, I will let you get started.
Thank you so much for having me today. I'm glad we were able to reschedule. I appreciate the kind introduction, a bit of a walk down memory lane. But starting at the present, I tried to both approach sort of high-level funding opportunities at NHLBI and address the changing landscape at NIH, but also come into the weeds around implementation strategy testing. And so let's see how we do with that intended set of goals. Before I get into things, I need to acknowledge that I have nothing to disclose and that the contents of the presentation should not be construed as representing an official position of the NIH or DHHS. So just in terms of orienting ourselves, which sounds like something I don't need to do, I'm going to address this blue circle at the end in terms of dissemination and implementation research, which I'm sure you all are aware of in terms of their definitions. So again, I won't spend a lot of time here, but really focusing today on implementation research. So the scientific study of methods to promote systematic uptake of evidence-based interventions. And then I centered this slide because in many audiences with whom I speak, there is this conflation of implementation and implementation research. And even when there is not, I think the point I'd like to make here today is that we need to do more in terms of hypothesis-driven testing of implementation strategies that allows us to draw generalizable conclusions about how implementation happens. And so I titled my talk, "The Next Generation of Implementation Strategy Testing," because the next generation helps us think about a newer, improved version of a product or technology, implying significant advancement, new features, or a fresh approach compared to what came before, as this group of individuals sought to do. And so I'll kind of anchor us in what evidence do we have to date around implementation strategies, including that which came specifically from NHLBI after I give a bit of a overview from the larger field. So it's really exciting to see that 25 years into our field as a formalized area of scientific inquiry, we have these systematic reviews of discrete strategies, as well as a recent publication in 2024, a systematic review of a host of discrete strategies that Lauren Ashcroft and colleagues published. So this is suggesting that enough testing has been done around strategies like audit and feedback, like learning collaboratives, and others. Enough studies have tested these that we can try to accumulate knowledge about how they're working in different contexts. So the QR codes should take you to evidence visualization tools that emerged from these types of systematic reviews in case you want to play around on your own time. But I thought I'd put up for you this one figure from the systematic review of empirically tested implementation strategies across health and human service settings that was published in 2024. I understand that you probably can't read any of the words, so I will walk you through what I think are some important highlights. And to be quite frank, what I'm about to sort of feature for you are hypotheses based on my own observations of the field that I'm hopeful that the authors might empirically address in the coming weeks or months. So what you see are these sort of frequency distributions of discrete strategy testing that is housed in this particular systematic review. And you see a predominance of strategies like audit and feedback, external facilitation, and clinician implementation teams, less so of the latter discrete strategy that I named, but audit and feedback and external facilitation are just ever so present in implementation science as discrete strategies for testing. And I think that is largely driven by quality improvement predating this field of inquiry implementation science. And those are two discrete strategies that go hand in hand from a quality improvement perspective. And I'm sort of trying to walk this chronological evolution of strategy testing that I feel like has transpired over the years. And so after QI, was on the scene, we saw this sort of hyper focus on intrapersonal, educational oriented implementation strategies. So the green boxes capture education and distribution of educational materials. This idea being that, if providers simply knew about and understood what the evidence-based intervention was, then they would be able to deliver it well. And then you saw this combination of QI strategies where you'd have some audit and feedback. Look at your performance on this evidence-based intervention. We'll give you knowledge so that you can increase your delivery of the evidence-based intervention. And unfortunately, those two types of strategies together still didn't allow implementers to hit the mark. And so you saw this acknowledgement that adaptation matters. And so the orange box is capturing promoting adaptability and tailoring strategies as discrete approaches that came on the field in more recent years. And so I just think that's interesting for us to consider what are the implementation strategies that are being tested most, and maybe why that would be the case. But one of the key findings that this team stated, and I just wanted to go back a moment and share a quote with you. They put in their discussion that we found evidence is lacking for most of the implementation strategies, that most studies employed combinations of strategies, and that implementation outcomes, which they categorize by the re-aim dimensions, have not been universally defined or applied. And then they go on to say that many of the strategies were not tested sufficiently to even draw conclusions. So hence why I'm suggesting there's a next generation of implementation strategy testing that we can embark upon together. So when I arrived at NHLBI, the team here in CTRIS, that's the Center for Translation Research and Implementation Science, had been wrapping its arms around the NHLBI investments in implementation science over the preceding 10 years. So what you see on your slide on the left is a depiction of the NIH investment in implementation science beyond NHLBI, but including it. And it reflects a five-fold increase over the 10 years, with the gray bars ticking upward. And NHLBI has 13% of the share of implementation science awards. These are competing awards across NIH. So indeed, NHLBI has been one of the leading institutes at NIH investing in implementation science. However, what you see on the right-hand bar chart is that although NHLBI's investment in implementation science has increased fourfold in the last 10 years, it's still about 3% of our competing award dollars. And so this high-level finding suggests there's more that we ought to do as an institute to stimulate investigator-initiated research in implementation science. So this was interesting enough for NHLBI as a whole, but CTRIS really wanted to get its hands dirty and better understand, well, what did the implementation science studies over the last 10 years look like? And so here's just a smattering of details that implementation science at NHLBI has predominantly focused on heart conditions. But about 25% of the competing awards were focused on lung conditions, 9% on blood, and only 2% on sleep. And I'm not sure if you're aware, but within the Division of Lung Diseases sits the National Sleep Center for Sleep Disorders Research, and that cuts across NIH. And yet there's very little implementation science on sleep conditions being conducted, at least as of 2023, which is what this data reflects. You can see in the middle of this table the various frameworks that teams were utilizing within their implementation research at NHLBI. A lot of folks really leveraging the REAIM evaluation framework, which centers reach, effectiveness, adoption, implementation, and maintenance. But then we see about a third utilizing the CFR, or the Consolidated Framework for Implementation Research, in their studies. And then on the right-hand side in the pie chart, giving you a sense of how the studies leveraged the hybrid types. So type 1 being a predominant focus on effectiveness outcomes, of which there were 6% that we could tell from their specific aims page. I should note we did not code throughout the research strategy. We just simply didn't have the resources to do that. But within the aims page, we saw that the majority of the implementation science awards were actually not a hybrid type at all, with almost a third showing up as a type 2, where there's co-primary emphasis on effectiveness and implementation outcomes. So we got even more curious about the implementation strategies being tested. We decided to take advantage of Waltz and colleagues' categories for implementation strategies that you see on the screen here, of which there are 9, and within which they bucket the discrete strategies that come from this ERIC compilation. And ERIC stands for Expert Recommendations for Implementing Change. So the ERIC compilation has 73 discrete strategies that map onto these 9 different categories. And we did our darndest to adhere to that compilation when we were coding the competing awards captured in our portfolio analysis. So this is kind of like NHLBI's systematic review of its portfolio of funded awards in the implementation science space. And you might be disappointed to learn that I'm not going to feature results themselves for you today, but instead talk about 6 opportunities to advance the next generation of implementation strategy testing. So I'll try to spend a few minutes on each of these opportunities that are informed by the results of our portfolio analysis, and then I'll wrap up the conversation today with ways in which that you could be submitting your research ideas to NHLBI or NIH as they pertain to implementation science. So first up is the taxonomy or compilation. So we did our best, as I said, to apply the ERIC compilation of 73 strategies and 9 categories. But we found that it was important actually for us to evolve from the ERIC compilation to include a whole new category. And this is up for debate, and maybe we'll get into it together today. But we saw so much being proposed in our awards to improve intervention fidelity and access that we wanted to name that and not lose sight of that as we were summarizing our investment to date. So within that category, we housed strategies like developing an EHR tool for eligible patient identification, adapting the intervention itself to improve access to it, patient navigation to support access to the intervention, health coaching to drive fidelity to the intervention, use of telemedicine to support access, and then intervention-related materials to consumers or patients themselves. We also, through content analysis, named new strategies beyond those that are included in the ERIC compilation. So supporting clinicians is one of the categories, and in there we named strategies like clinical decision support, leveraging lay health workers, developing referral systems. Within the category of adapt and tailor, we named embedding care in the community context, co-designing or co-developing implementation strategies. Within utilized financial strategies, we saw enough studies that were generating and feeding back return on investment data that we wanted to capture that. Within train and educate, we captured building community capacity, and finally, developing stakeholder relationships. We named developing partnerships with local health ministries or departments of health as a strategy. I'm not going to get into the fact that we also grappled with whether or not new definitions were needed. That's a little bit in the weeds today, but you'll hear me circle back to this at a higher level in a slide or two. On each of my slides, I have questions for the field, because I think if we are to advance to this next generation of implementation strategy testing, we have some really important questions to address together. Who is responsible for keeping compilations like the ERIC compilation up to date? There have been a number of evolutions of the ERIC compilation, including one called SISTER, which is an abbreviation that stands for something very important that I can't remember in this moment, but it has to do with strategies deployed in the educational sector. There have been evolutions of ERIC, I think, into the global health space. And yet our fearless leader, Dr. Byron Powell, has not published an update of the ERIC compilation in over 10 or 12 years. And the question is it his responsibility? No, I do not think so. But then how do we as a field do this? And perhaps more importantly, is there a way for us to build a living review of implementation strategies, leveraging some of the technological advancements in front of us so that we can more nimbly and in almost real time understand where strategies are being tested, what evidence they have of their overall effect, but more importantly, of the mechanisms of action through which we expect to see change. So that's the first opportunity that I see the field poised to grapple with. The next observation we made in our portfolio analysis, and I alluded to this moments ago, is this desire to expand strategy definitions or how we characterize strategies to explicitly include function or to include something about mechanisms. So when we looked at the ERIC definitions, which really were born out of this consensus exercise using a Delphi approach of experts around the globe to settle on labels for the discrete strategies and then offer definitions for the field, there were no parameters actually given to us experts when we engaged in this exercise. So what constitutes a useful definition for that specific labeled discrete strategy? And when we were trying to apply those definitions to our portfolio analysis, we saw that, some of the definitions had a to in it, which would suggest a function is being used to sort of anchor that particular discrete strategy. But many, and I should have pulled the actual numbers on this, but many of the ERIC definitions say to implement, which of course is this higher level function that you hope it would achieve, but is not a precise function that allows you to differentiate between strategies. So Brian Mittman and colleagues are doing a lot of thinking in this space, and I've got one paper of theirs up on the screen for you, and it's my understanding that they're working on two others to really help us unpack form versus function as it pertains to implementation strategies. And briefly, that core functions reflect the core purpose of the change process that a health intervention seeks to facilitate, whereas the form are these specific activities that might be customized to local contexts and that are needed to carry out the core functions. So questions for the field in terms of strategy definitions or characterizations. How do we make sense of this proliferation of tech-enabled approaches, telemedicine, remote supervision? Are these forms? Are these functions? Are these interventions? Are these part of this? Are these part of the intervention? Are these implementation strategies? These distinctions matter, and you'll hear me talk a lot about being precise. What are we calling this? What is it? How is it serving us? How is it different from other things? And I think we need to grapple with these tech-enabled approaches in particular, but also to be able to think carefully through, and I'll move to my next slide for this point, form versus function versus mechanisms, because a lot of people say that functions and mechanisms are the same thing, whereas I think there is an important difference. And so what I hope to see the field do moving forward is that a definition offers activities of this that are encompassed in the strategy, which are currently poorly operationalized, but that hopefully within publications about implementation strategy tests, we see this listing of activities, this more defined operationalization to reflect the form, and that would allow for transparency of what was actually done, help people think about costing so that they could fund an implementation and replicate what it was that actually occurred in a study. But I suggest more important is to address the function. So what is the purpose of what you're going to do? What is the goal, which offers a justification for the strategy selection and operationalization, but also for tailoring. And then perhaps most important is to address this mechanisms question. How or why is what you are doing going to resolve a certain barrier or achieve a certain outcome? And we see a growing number of studies that try to articulate and establish mechanisms, but this is really the minority still to date. And then here, I think maybe what I'll do is spend a moment on these theory-informed implementation strategies that like those that come in the behavioral economics space. When we saw those in our portfolio analysis, when we label them using the definitions that are provided by ERIC, we lose the nuance that is the theory that informed it. I'm looking at examples on the other side of my screen to see if they're worth bringing up. And I think what I'll do is I'll come back to it if people want me to elaborate as we move into this discussion today. Just being sensitive to time, I'll highlight the questions for the field that emerged for me out of this particular part of the methodological observations. So can we define strategies based on their function? What is made possible if we center functions? What is made possible if we are more articulate with respect to the forms of our strategies? And what can we then do and when mechanisms are articulated and tested? The third observation is around abstraction itself of strategies for replication. So the majority of the studies that were captured in our portfolio analysis started with conducting a local needs assessment and assessing for readiness and identifying barriers and facilitators. And you can imagine then how limited we were in being able to actually describe and characterize the strategies that then the teams went on to test. Because if they were saying they were starting with a local needs assessment to then, identify barriers, they were then going to be, articulating, operationalizing strategies. So, how substantively do the data from a barrier and facilitator assessment drive the strategy selection and the operationalization from study to study, setting to setting, and geography to geography? Is it critical that a barrier and facilitator assessment is the starting place? Could a needs assessment yield practice-based evidence for implementation strategy articulation? So we saw maybe only 3 studies that did that, where there was actually successful implementation happening in a particular region or a particular clinic or a particular setting, and they could start from what actually can work in the real world and then test that in other settings where implementation is suboptimal. And the other piece of this is just that strategy tracking remains laborious, requires expertise, is quite time consuming. And so can the field help make strategy tracking more accessible was another question that we wanted to put out there. Sort of related, there's this observation we made about using what we already know from implementation science to give us a head start on strategy selection. So I mentioned that so many of the studies started with assessing for readiness and identifying barriers and facilitators. Well, from a data perspective, that particular strategy was coupled with Taylor strategies in 34% of our entire pool of awards. And then we had adapting the intervention included in 65% of those studies. And almost no mention of theories, models, or frameworks within those studies. So here you have this it sounds pretty de novo, based on community input to surface barriers, tailor strategies, adapt the intervention, and not leverage implementation science, theories, models, or frameworks to then select and operationalize strategies. And several of these type 2 and type 3 studies where you have an emphasis on implementation outcomes, they didn't even delineate the implementation strategies they intended to test. The caveat is important to make that we were coding in the specific aims, but I think if you have a type 3 study and you're not saying in your specific aims what strategies you're testing, that's a pretty risky place to start. So questions for the field: do we need to approach implementation with a blank slate with this needs assessment? How do prior implementation studies help us get started with respect to implementation strategies? If we define pre-implementation strategies by their function, perhaps they work differently than they might sound. So this barriers and facilitators, this needs assessment, these are discrete strategies that I think at face value function to surface needs and barriers, but what if they actually function to build buy-in with the community? That might help us operationalize them in an important way. And as a funder, I wonder, how do you budget for a study if you don't know what strategies are needed and what you're planning to test? I just feel a little bit perplexed by that, if I'm being honest. And then I think the last thing for us to noodle on here is, have we learned enough about strategies that we can sort of start farther ahead than needs assessment plus tailoring? Is there something about the nature of the intervention within the specific target context and the intended population that tells us what the core discrete strategies are out of the gates? That's a question, an empirical question, I guess, for you all to help us address. Okay. The fifth of 6 observations is this challenge of distinguishing between the intervention and the strategy itself. So we have these branded interventions that showed up in our portfolio that when we looked at it, we thought these are actually bundles of discrete strategies. So I can give you a couple examples here. There was one called Office Gap. a patient activation intervention to improve communication and patient-provider partnerships through training and shared decision-making, and then a guideline-based checklist. Those sound like discrete implementation strategies put together to then support the implementation of an evidence-based intervention that was targeting clinical outcomes. There was one called ADUNU, which had two core evidence-based technologies. So using a handheld echocardiography in community settings and a nurse-led registry-based delivery as secondary prevention. And we had one called iTransfer-HF, which was comprised of a home health care nurse visit and additional activities. So the questions through the field here are, does this distinction matter between, if we try to differentiate between interventions and discrete strategies, to whom does it matter? I've often argued it matters from an evidence synthesis perspective. If people are trying to implement a similar but different intervention, if they can understand what are the strategies that worked to implement X intervention, then they might be able to pick up those strategies. But if the bundle of strategies is called an intervention itself, we might not be able to support implementation beyond that particular intervention. What do we lose from calling an intervention that seems like a package of discrete strategies? It kind of sort of addressed that, but would love to dialogue more. And when and why do we need to be sure to recognize intervention components? And of course, that matters when we think about tailoring and what can we not lose, or when we think about adaptation, what do we need to retain so it's a fidelity, consistent adaptation. So finally, in terms of the next generation of implementation strategy observations that we might want to take on as we move forward with this work, there were 45 strategies that were tested in fewer than 20 of the, I think it was 200 or so awards included in this particular analysis. 34 strategies were tested in fewer than 10 studies. Among the least tested categories were engaging consumers, feels like a miss, utilizing financial strategies, and changing infrastructure. My hypothesis is that these underutilized or least tested strategies and categories might be the most powerful drivers of change when you think about their functions or their mechanisms of action. But the cost or burden of executing on these particular strategies might be keeping people from doing just that. And so thinking how can we increase testing of those types of strategies to see if they really could return on the investment and implementation. So how do we overcome the inertia of familiar strategies? Educational strategies are the most commonly tested. External facilitation, very similar to what we saw in the systematic review. We saw, obviously, in our portfolio analysis. How can we make initial strategy selections based on their promise of impact versus their feasibility? How can we leverage simulation to test costly, complex, or bundles of strategies so that we can get into the space of some of these more burdensome strategies to see if they are really worth the investment? So I like to wrap this by just acknowledging the incredible advancements that several in the field have made to date, that if we brought them together, I think we can really exponentially advance the empirical knowledge gained by implementation strategy testing. So first up, I was part of a team that published on causal pathway diagramming as a way to articulate the causal chain of an implementation strategy, from discrete strategy to its mechanisms to the barrier and proximal outcomes, as well as thinking through preconditions and moderators. But there's also groups who are writing about how do we theorize more in implementation science to get the causal thinking going. We've got a group who put forward the implementation research logic model that really unpacks the activities, the components that you're thinking about in an implementation, including mechanisms to some degree. You've got another group who's running with mechanism mapping and giving some examples of applying that retrospectively to make sense of implementation efforts that have not succeeded. We've got several different ways that we can specify strategies. And one example is up on the screen from a group in Canada. We've got strategy reporting recommendations that help us with transparency and replication. We've got strategy form versus function, which I talked about a little bit earlier, the core component versus the adaptable periphery, and sorry about those pop-ups. I'll do my best to keep them from getting in the way. We've got multi-phase optimization strategy being brought into implementation science more and more. We've got nice work on adaptation. When is it fidelity consistent? We've got strategy modification guidance. We've got clarity on tailoring strategies. And in fact, the Cochrane Review update of the Baker 2015 was just accepted this week. And so you'll see more on that soon. And then also the longitudinal implementation strategy tracking system and other contributions that have been made for the field of implementation science in the last 20 years that I think if we bring these tools, these methods together, we can really take a giant leap forward for the field. So how can we do this? Well, you folks are the ones in charge. So we really hope that you'll submit to, this is the PAR 25144, Dissemination, Implementation, Research, and Health, the R01. Other institutes have signed on to the R03 and the R21. And we've got, I should have updated it with the forward-looking receipt dates, or maybe we've got some of those on here. But so it's still on the street. I think it expires in 2028, so it's up for renewal then. We are here for technical assistance. That's the term we use to say we're here to support you. So if you have an idea that you think might be responsive to this particular RL1 or any other notice of funding opportunity that NHLBI is signed on to, program officers are at the ready. That's their job, is to support you to figure out which NOFO or funding opportunity is the best fit, what mechanism might your idea be ready for, and how to be responsive to things like this program announcement. I think you'll notice that this program announcement explicitly does not touch hybrid type language because all are within the purview of this PAR. What really, when the hybrid type sort of matters is when you're choosing study section. So there is not a direct link or required link between this PAR and the SIHH study section. That's the science of implementation in health and health systems. Many of the applications that come in through this PAR do go to that study section, but that study section primarily tackles type 2 and type 3. And there's other study section at the Center for Scientific Review that might be better for the type 1s. And I'm happy to talk more about this in just a moment. I thought this would be useful just to highlight that depending on your career stage, there might be a specific type of mechanism that is best suited to you. On the left, having those that really do intentionally feature training and career development, and those on the right for independent investigators who are ready to lead their own studies or to lead mentoring of implementation scientists in the future. So I'll wrap with some higher level NIH related slides. So you've probably seen, and it's very important that you understand well, the unified strategy that the agency director published in August of 2025. On the left are some of the called out priorities, which is intentionally not comprehensive, but some of the top of mind key priorities for research that NIH would fund going forward. And exciting to see is implementation called out explicitly, particularly when it comes to HIV/AIDS research. But also that's one way that I make sense of this solution-oriented approaches in health disparities research, which is very much a priority for our agency and our institute. Our funding policies have evolved in recent months, and so the core tenets are up on the screen for you. You need to align with NIH's mission, of course. We will continue to prioritize scientific merit, and we'll consider peer review information in its entirety. And there have been some changes there as well. We need to make sure that we have a breadth of topics covered, that we support investigators across the career stages, and that we have geographic balance in our portfolio, and make sure that our availability of funds allows us to do all of those good things. So if you're trying to stay abreast of the changes at NIH, there's QR codes that'll take you to the NIH guide, which is where you'll see important notices coming forward, and where you'll find grant opportunities available. And then policy changes are featured on the right QR code. And hopefully, if you do struggle to make sense of some of these changes that are written online, you reach out to a program officer who can help you navigate how does this apply to your specific program of research. So on that note, I'll stop there and entertain questions and dialogue.
Fantastic. Thank you so much. That was excellent. As an implementation science nerd, I have a million questions, so that was great. And I think those of us in the audience doing more hybrid one early interventions probably also will have lots of questions and thoughts, but that was really great. Thank you so much for that broad overview. I see already some questions in the chat. I can start with those and then I can go towards my own. Please unmute. Let us know if you have any questions. Audience, but Ian had a question in terms of does the distribution of NHLBI IMSCI investment by condition reflect NHLBI condition-specific research more broadly?
Yes, I think so. I mean, I don't have the data in my hands right now, but our division of cardiovascular sciences is the largest division, which we see the most applications coming in for. So I think there is maybe not a one-to-one, but it is proportionate. Is that a question?
Makes sense. I saw another question here too about ontology has also been a challenge in behavioral intervention development research. Thoughts on whether AI can help efficiently integrate emerging research. I had a similar question when you were talking about the implementation strategy, like who should be updating these and helping to define these. Any thoughts about that from just the methodology perspective?
I hope so. There was an interesting conversation about a year ago when someone in the field made a statement that, well, you can't really synthesize implementation research. It's too complex and, really needs to be contextualized. And that sort of floored me and sent me to a place of disappointment that I had to quickly overcome. And I do hope tools like artificial intelligence, with obviously experts at the table to engineer the prompts and to validate and help it learn, it could be a way that we can actually wrap our arms around the various inputs and learnings that our field is intended to offer. Because if we cannot synthesize and learn across studies, how do we prevent an ironic gap from emerging where implementation science struggles to inform the practice?
Yeah, that makes sense. Along those lines of kind of the Eric strategies and expert compilation. Any thoughts on like who should be at the table in terms of proposing new strategies, defining strategies? Should it really be methodologists? Should, end users or clinicians be involved in terms of the type, like what is an implementation strategy? Because I know I've probably memorized those 73 strategies over the years, and it always feels like there is sometimes a gap of like, I'm not sure if there's something missing or if it needs to be updated in some way, but.
Yeah, I have the recency effect informing my first part of my response, which is to say that I think the more we see mechanism articulation and testing, the more important we acknowledge that the end users or beneficiaries of implementation strategies ought to be at the table from the get-go. Um, and I guess I say that because you could do this, I think, technical or theory informed linkage or mapping of a strategy and its function to a barrier through its mechanism. But if you don't really understand how the barrier manifests in a dynamic context, I think that you could misdirect an implementation strategy to activate the wrong mechanism. That's not exactly an answer to the question you asked, but I do think the short answer is we really do need implementers and the beneficiaries of implementation strategies to be part of the conversation, perhaps with methodologists doing the hard work of wrangling the insights.
Mhm.
But in terms of naming people, the only name I see on my screen is Rachel Tabak. And so I guess you're up, Rachel, to update the Eric compilation next.
Actually, I can highlight Laura Bayless has published specific implementation strategy for community settings.
Mhm.
And I've actually found that really helpful in my work as someone who works outside the clinical setting. So maybe just to put that out there as well.
Brilliant. If you have a paper that you could plug the link for in the chat, I'm sure people would welcome that.
Great. In keeping with this kind of because a lot of people are testing mechanisms in their behavioral interventions. Most of this is like very early, either piloting or feasibility. So we're not even quite even at the implementation stage yet. But, at least for behavioral scientists, like a lot of these, we review a lot of grants and proposals. Mediation analyses are kind of the primary way to really kind of think about the mechanisms at that stage. Can you tell this audience that some of whom, don't work a lot in implementation science, how that might be different when you're looking at the mechanisms by which a strategy worked, how is it similar and how are there some differences? I think in your paper, you even noted like mixed methods approaches to looking at mechanisms. And so I don't know if you want to talk a
Sure.
little about that. Yeah.
Sure. I mean, I think mediators and moderators can help point toward mechanisms,
Mhm.
and they themselves are not necessarily mechanisms, but they can shed light on or provide guidance to then naming a mechanism, which is sort of like this label for
Mhm.
a set of processes, if you will. But for strategies versus interventions, I suspect that we have far more work to do on measures of mechanisms at the implementation strategy level than you do for the intervention level. And that's simply due to the relatively young state of our field versus more established fields.
Mhm.
And so Brian Weiner, I think it's about to come out, 6 new measures of very commonly implicated implementation mechanisms that are intended to be pragmatic measures that could be deployed in an empirical study. But until then, and based on a comment I made earlier about the import of people in the implementation experience themselves shedding light on mechanisms, mixed methods, I think, will continue to be really important.
Mhm. Mhm. That's great. Ian had another comment in the chat about to what extent are you guys applying the NIH stage model and NHLBI?
I can't say that it's front and center because if you quizzed me on it right now, I'd probably fail, embarrassingly. um, but I know that it is widely used across NIH, obviously.
Mhm.
So not wedded to it. How's that for a short
Yes.
response?
Okay. Fair. Great.
And I guess the other thing I'd say about it is sometimes that language shows up when we have IC specific, opportunities to elaborate on NOFO parameters, funding opportunity parameters, and implementation science often gets like caught up in like where are we and how do we make sense of that? But then you're seeing changes along those lines as well in terms of IC specific language and a move to consolidation so that it's easier for the investigator community to understand where does my research belong.
Yeah. Great. The behavior change wheel, there's another question. I know I use that a lot in our strategy design work as well, but even intervention design work
Yes,
about that.
absolutely. Such a critical contribution to the field. And I think that, far ahead of the larger set of implementation strategies in terms of understanding their mechanisms and the evidence for the behavior change techniques as well. I often describe from my perspective that perhaps because it came from more of a health promotion space, that there's a lot of intrapersonal, and I think when we are expanding, which I know the group does, but we have more work to do, I think, on some of the like team level, system level, policy level strategies
Yeah.
for the field to tackle.
Yeah, there is that grade for those who haven't seen it. I think it was Powell too, who some of the overlaps between the behavior change techniques and implementation strategies as well. I think he was one of the co-authors.
Yes, that is, yes, you're familiar.
Yeah. Okay. In an effort, like we said, to start 5 minutes late and end 5 minutes early, so to give people back some time. Thank you everyone so much. Thank you, Cara. That was an amazing, amazing talk. I think it's so hard to be able to speak to so many different, such a broad audience of like true implementation scientists and early, intervention development folks. And so, that was just amazing and phenomenal. And we appreciate your time and effort and all the work that you're doing to really push forward this work from the NIH's perspective. So thank you.
My pleasure. I'm glad it maybe hit the mark. Hope
Yes,
you'll
yes,
stay
good.
warm this weekend.
Very good. Thank you. Take care.
Bye bye.